Chapter 7, alcohol dependence, tobacco use, and substance abuse. And as you read through the chapter, keep the objectives in mind. You want to be able to describe the effects of alcohol, discuss the problem of alcohol use disorder, discuss strategies for prevention and control of alcohol use, describe strategies for prevention and control of tobacco use, define drug abuse and misuse, identify commonly abused psychoactive drugs, define the criteria of substance use disorder, and discuss strategies for prevention and control of substance abuse. Okay, so as we go through this slide, I'll give you my thoughts on the quote unquote gateway drug. If we continue on with this second bullet here, meaning that the use of these drugs often leads to one to experiment with other psychoactive drugs. Okay, so my thoughts are, if just because you use one illicit substance doesn't mean that you're predisposed to progress to harder drugs, a more powerful drug. In some instances, I can see where that would occur if we're dealing with drugs within the same class. So if we talk about CNS depressants, as tolerance builds up, you'll need to take more of the original CNS depressant or find a stronger, more powerful CNS depressant. But however, I think that if you were to take two identical people, this is a concept here, two identical people, and you tell them that this substance that both of them are interested in experimenting with, you tell them, okay, well, this substance is illegal, right? It's against the law to use that, be in possession. One person, that may be enough to say, okay, well, then that's that. I won't engage in that behavior. And the other person is like, well, it's against the law if I get caught. So what I'm saying here is that maybe there's other differences that explain progression to other drugs, right? For example, the example I just gave you, one, right, telling someone that what you're thinking about doing is prohibited by law, right? If that's enough to stop that person, okay, then we won't suspect that they're going to have any issues as long as they're aware of what's legal and what's illegal. The other person, that's not a deterrent. Well, it's not going to be a deterrent with other substances that they may look to abuse. So, gateway, I think you have to consider the context when you are using that terminology. Okay, the other things that we see on this slide are they're talking about risky drinking. And if we look at risky use for women and persons older than 65 compared to men in age 65 and younger, we see that there's a difference in what's considered risky use. Okay, so for women and persons older than 65, drinking more than 7 drinks per week or more than 3 drinks per occasion. So you sit down, you start drinking, you consume 3 drinks, right? That's a single occasion. Risky use for men, we see that drinking more than 14 drinks per week, so it's double, or more than 4 drinks per occasion. So we have one additional. Many different reasons why that's the case, because we're talking about intoxication is the outcome variable. So how much alcohol does it take to reach that point of intoxication? Since we're talking about quantity or frequency, we have to think about, okay, well, there's got to be some type of difference, a volume difference in women and men. Being older than 65, younger than 65, there'll be some density issues, which may attribute to maybe a dilution effect of a larger individual. So as we go through, just keep this in mind. If we're looking for criteria of frequency and quantity of alcohol consumed, and then right now we're looking, okay, well, there's other things involved, such as gender and age, that may dictate what those criteria actually are. Okay, the ICD-10 is the International Statistical Classification of Diseases, 10th edition. DSM-5 is the Diagnostic and Statistical Manual of Mental Disorders, 5th edition. All right, so they both contain criteria that assist with making diagnoses. So problem drinking, okay, that's a label that's placed on a particular pattern of drinking, is a precursor to alcohol use disorder. So one prevention strategy may be to start recognizing problem drinking, right? So here, the use of alcohol accompanied by alcohol-related consequences. So we're looking at how drinking is impacting a person's daily routine or their lifestyle. Are they experiencing consequences like a DUI, maybe public intoxication, maybe being asked to leave a restaurant or a bar, that sort of thing. So being able to recognize that, hey, normal drinking patterns shouldn't end up with, the user experiencing those consequences. So when they do, we want to start paying attention. Is this person struggling with an issue that, needs some early intervention, as opposed to waiting for some big dramatic event to happen before we say, oh, well, drinking actually is a problem for this individual. So that's one of the challenges we'll run into dealing with alcohol and other substances of abuse is when you start to recognize the person is engaged in that behavior, whether it's legal or illegal depending on their age or the substance, and being able to approach that person and say, hey, I've noticed that when you drink, these things tend to happen, and I'm concerned. You may have those thoughts internally, but do you actually sit down and reach out to the person? Until you do that, then your prevention approach isn't going to be all that effective. Okay, so I mentioned alcohol use disorder. So in order to diagnose someone with alcohol use disorder, you want to look through these 11 criteria, and depending on how many of these events are present in the individual's drinking behavior, kind of dictates or specifies the level of alcohol use disorder. So everything is worded according to the past year. So over the last 365 days, the presence of 2 or 3 of the following symptoms indicates a mild AUD, 4 or 5 indicates moderate, and more than 6 indicates severe. If you want to keep track of these, and you can read through the 11 criteria. Okay, so remember, you're going through doing an inventory, and you're just checking off how many of these 11 does it actually at play dealing with this individual. Okay, alcohol processing, you can read through that, just how alcohol is made. You can look on YouTube. Okay, so the effects of alcohol can be influenced by physiology. Women may react differently to the same volume of alcohol as men. That's why there's some differences in risky use that we talked about earlier. This is a generality, right? In general, there's going to be cases that don't fit this. But women tend to have a higher proportion of body fat. And fat itself contains less water than muscle. Fat absorbs less alcohol, so more of the alcohol that's consumed is available in the bloodstream, which increases blood alcohol concentration. So basically, that's how that works. We also look at this last bullet, an enzyme called alcohol dehydrogenase. That's what metabolizes alcohol, so breaks it down so that it can either be utilized by the body or eliminated by the body. The enzyme is slower in women, and therefore women tend to have higher BACs, right? So you have more body fat that's not absorbing as much alcohol as muscle because of water. So more alcohol is in the bloodstream. If there's also a weaker response to the enzyme, and that alcohol can be available longer. So the effects of intoxication are going to be impacted as well. Okay, so GABA is a neurotransmitter that acts as an inhibitor, right? So it restricts cellular activity when it lands on those cellular receptor sites. Alcohol enhances its inhibitory effect, which can result in feelings of anxieties, right? So alcohol is manipulating how the body regulates itself, and that dysregulation manifests itself in the symptoms we associate with alcohol intoxication. Okay, various blood alcohol concentrations. As the concentrations increase, we see, there's going to be more of a depressing effect on the central nervous system, and you start to see that their motor function starts to decline, cognitive function starts to decline. We get up here into the higher VAC, it starts to act as a sedative effect. If we go here, person in stupor but is conscious, get up to 0.35, the person in a state of surgical anesthesia, right? So anesthesia is a central nervous system depressant, is in a higher concentration. But if you consume enough alcohol quickly enough, you can start to see the effects of same thing as an anesthetic. And then 0.4, 50% of people in this state die from lung and heart failure. Right, so it's suppressing your central nervous system activity, including the signals that go out to your heart and lungs to say, okay, beat or breathe. So they become depressed to the point where they're not functioning, and you can no longer sustain life. So the way that people consume alcohol, typically a person will pass out, get drowsy, go to sleep at a blood alcohol concentration that's low enough that's not going to there's not going to be a threat for mortality. However, depending on how the alcohol is consumed, the strength of the alcohol, if you're just knocking them back, right, you're making all that alcohol accumulate in the system, that's going to drive up the BAC because it's going to you're going to drink faster than your body can metabolize the alcohol. Many years ago, there was a drink called Four Loko, and Four Loko had alcohol combined with caffeine, right? So caffeine's a stimulant. And the problem with Four Loko, and I mean, you could also do this with like a Red Bull and vodka, anytime you mix a stimulant with alcohol, the stimulant actually delayed the person's response to a high BAC in terms of passing out or dozing off, where kept them going so that they could continue to consume alcohol, which allowed BAC to get to a point where, okay, now we start to have health concerns because of the present effect of the amount of alcohol that's being consumed by the individual. Okay, short-term toxicity of alcohol, right? So these are all the short-term effects that we're familiar with, and there are many long-term effects. Wernicke's, encephalopathy, that's something that can happen due to chronic malnutrition because alcohol has a caloric property. So when you consume alcohol, those calories go to person feels a sense of satiety. Meaning, when you're hungry, then you eat, you're no longer hungry. That's satiety. So the calories can make you feel like you're not hungry, but those calories are empty calories. There's no or very little nutritional value from those. So malnutrition can result in people with alcoholism issues. Cortical psychosis, fatty liver, alcoholic hepatitis, right? These are things that you may or may not heard of before. Cardiomyopathy, right? Damage to the heart muscle because of depressant, coronary heart disease. So there's a lot of health outcomes, negative health outcomes that we want to take a look at, because one of the ways that we could lessen the burden of these conditions is to alter the alcohol consumption behaviors in the population. Okay, fetal alcohol syndrome, right? So this has long been established that, a woman that's pregnant who consumes alcohol during pregnancy, well, they share the bloodstream with the developing fetus. And when they add alcohol to the bloodstream, well, that's going to be also delivered to the fetus, and it can result in fetal alcohol syndrome. And I think, if you're not aware of what fetal alcohol syndrome is, I think most people are aware that consuming alcohol during pregnancy isn't something that should be done. Yet, we start to see this, 9.8% or 98 per 100,000. The estimated prevalence of fetal alcohol 14.6 per 10,000 people. How does that happen? How does this happen still that people in 2023 are consuming alcohol during pregnancy? Okay, the CAGE questionnaire. CAGE stands for cut, annoyed, guilty, and I. And it's based on the number of yes responses. So if you have one yes response, after asking yourself these 4 questions, there's a potential for alcohol abuse. If it's 2 or more, then we suspect that alcohol abuse is present, right? And the CAGE, right? So cut, annoyed, guilty, I. That's where that comes from, based on these 4 questions. Okay, withdrawal syndrome associated with alcohol. So a couple things that are happening. So you've heard of the term homeostasis, right? It's where your body is able to react to the surrounding environment and adapts, be it by altering metabolism. Well, withdrawal symptoms can be a byproduct of those adaptations. So the body maintains balance to an alcoholic. You take away the alcohol. Well, the body is now going to be kind of out of balance because it's made all those adaptations through the presence of a CNS depressant. So you take that CNS depressant away, you have all this sympathetic nervous system adaptations that have been ramped up. When the person is going to start feeling this tremors, rapid heartbeat, hypertension, right? That's the sympathetic nervous system is out of whack because it increased due to the chronic presence of alcohol. You take the alcohol away, now all those adjustments, it takes a while for the body to kind of get away from that. There's also going to be a psychological component to the dependency, but so stage 1, you go out longer, development of hallucinations, and maybe auditory, visual, tactile. Like so the person's not is losing their grasp on reality. Stage 3, delusions or false beliefs, disorientation, delirium, amnesia. Stage 4, seizures. And so these stage 3 and stage 4, that's what we call the DT. And that's a pretty serious medical situation. So, if someone is going to be transitioning away from alcohol, and they get up into stage 3, stage 4, they want to do so under kind of supervised condition because things can go, pretty unfortunate for the individuals involved. Okay, so alcohol impacts various aspects of life. So, the therapy that's delivered needs to be kind of comprehensive to address any of those aspects of life that's been impacted. So having a psychological, social, medical, and behavioral kind of attention given to the treatment of the alcohol use disorder. That's something that, we should be expected because it's a complex problem, requires a complex solution. Okay, the epidemiology of alcohol use. So read through, look at the stats, look how the stats are changing. 3 million deaths worldwide. 7th leading risk factor for both mortality and disability adjusted life years, right? So, living with the condition that's being diagnosed with until it ultimately, you die from that. We're responsible for 6.8 of age standardized death in males and 2.2 of age standardized death in females. Remember, age stabilized simply means that we're weighing the results so that we can compare different age distributed populations to one another. Between 1990 and 2017, adult per capita consumption of alcohol increased from 5.9 liters to 6.5 liters, right? So alcohol consumption is increasing and expected to continue to increase, which isn't necessarily a problem. We have to look at the other data, but anything in excess can be problematic, especially in terms of population health. So that's why we take a look at these things. Okay, so if we look in the United States, so the National Survey on Drug Use and Health, so there's a lot of data that, and people can access this data, and you can look at it yourself. In 2016, it was found that 136.7 million Americans aged 12 or older. 12 or older is the age cutoff that's used for a lot of the surveys and questionnaires employed by the U.S. government, just to give it insight on across the whole population. Binge drinking in the last month, and heavy alcohol use. So again, we're looking at patterns of behaviors when it comes to alcohol consumption. As those behavioral patterns change, right, we want to kind of start taking a look there. Okay, what's driving this? Are there anything coming over the horizon we need to be aware of in terms of potential public health issues? All right, levels of prevention. We've talked about this before. So primary, secondary, tertiary. Primary is when we want to keep status quo. We're not working with a group of individuals consuming alcohol. We want to keep it that way. Secondary prevention is for people still in the behavior. Maybe they haven't developed the condition, but if we get them to change the behavior, right, we kind of improve their prognosis. And then tertiary. These are individuals with chronic conditions related to the behavior, and tertiary prevention really is helping them manage the condition at that point. So if we look at primary policy level approaches, again, all of these things are, we have a group of individuals that aren't engaging in the behavior. How do we keep it that way? And you start to see these policies are aimed at doing that. Right, restricting alcohol advertisements, decrease television, right? We're trying not to normalize the behavior, zero tolerance and maximal rate. We're saying, look, this is illegal, right? It's consumed this way, or this is being discouraged. Just kind of, again, setting the expectation, setting what the norms are supposed to be. Primary education, again, those type of things. So secondary, right? So here it is. We're trying to capture individuals that are engaged in the alcohol consumption behavior, and may or may not have developed a condition. Maybe they're progressing towards a condition related to alcohol consumption, but at some point it's early on, and there's benefit that the person can receive by changing the alcohol consumption barriers, right? So that's who we consider in the secondary prevention approaches. So screening, right? Identify individuals that may be engaged in patterns of alcohol consumption behavior that are alarming, but they're not aware of that. So screening kind of brings us to their attention. Maybe they are progressing, or they're experiencing physiological change as a result of the alcohol consumption, but again, they haven't noticed because there haven't been any symptoms that have been present. So screening can help identify these individuals. Primary care intervention. So a person maybe injures themselves or gets in a car car accident, because of a DUI, but whilst they're receiving injury care, right? They can say, look, what led this to injury? Oh, it was alcohol related. Well, here's some, information about alcohol use disorder. Intensive intervention in specialized setting. Again, we're trying to get people to change behavior. Behavior change is always going to be challenging. And then tertiary, usually, again, rehabilitation centers. These are people that the condition is advanced. In the case of alcohol problems, it's probably going to be very disruptive to social life and home life and that sort of thing. So getting them into some intensive rehabilitation therapies is probably what can be done at that point with the individual. Okay, so you can read through these in the book, some public health interventions. So these are going to be actually programs that are designed to alter or change alcohol use behaviors. So the Pragmatics Project Integrates, communities mobilizing for change on alcohol. So there's a lot of different approaches. So as you read through them, just to see where are the similarities, what are the differences, what are the hallmarks of each of these interventions? Like what were they known for? Okay, tobacco use. So we're transitioning from alcohol to tobacco use. The word use, that's what implies the behavior. So, we're talking about substances, there's alcohol, tobacco, and other drugs, typically how they're presented, because alcohol and tobacco are the two major categories. And then all other drugs or substance use and abuse is kind of what we'll end this on. But so tobacco use, smoking cigarettes, cigars, pipes, BDs, smokeless tobacco, vapes that contain nicotine, that usually gets thrown in here. So that's what we're after, considering tobacco use. And why? As a causative factor, okay, I've talked about causation and that sort of thing. So there's a lot of health outcomes that are negatively impacted or negatively associated with tobacco use. Okay, smoking in pregnancy, just like consuming alcohol during pregnancy. People may not be that aware of the exact effects of smoking on the fetus, but I think again most people are aware that smoking is not something you should do during pregnancy, because it does have an effect on the fetus during pregnancy. Leads to low birth weight. It's relative. It's less the birth weight is lower in babies that the mother smoked during pregnancy, but it's not that much of a difference. And I'll give you an example of kind of the thought process. So I used to teach at Mississippi State University, and I had a graduate student, and she was doing her thesis. And it's centered around her employment. So she worked for the state of Georgia, and in this program that was designed to work with pregnant teens to look at, what are the reasons that they got pregnant in the first place, and can we get them to change those factors so that unwanted pregnancy isn't something they have to deal with in the future, right? So working with these young girls, they, the staff started noticing they smell like tobacco smoke, like cigarettes. And they sat down with a couple of them and said, what's going on? You smell like smoke. We smoke. And so the program staff reacted. Oh my gosh, these girls don't know that smoking's harmful for the baby, so they put together education components, and they went through it. And girls were still smoking. And finally, they said, "Why? Why are you smoking?" We just went through all these modules, talked about how your smoking impacts the development of the fetus. And the girls basically felt that if they smoke, right, the babies are going to be smaller. And if the babies are smaller, it's not going to hurt as much when they deliver them. Yeah, that's that's the reasoning, right? So you start looking at this, how is this even possible? Well, there you go. Here's an example of that. So it's a challenge, understanding why people do the things that they do. Yeah, you can't really apply logic to the decision-making process. You try to understand that because people make all sorts of decisions for all sorts of reasons. Okay, the epidemiology of tobacco use. So epidemiology paints a picture. Basically, it provides all of the details of an event so that you have a better understanding of the event. So e-cigs, these electronic cigarettes, can be problematic because oftentimes they're viewed by the population as being a healthy alternative to cigarette smoking. Well, I don't think that there's been enough longitudinal observation data to say definitively if e-cigarettes are harmful or not harmful. With that in mind, tobacco exists for a number of years, decades, before it's finally determined that smoking is harmful. So the thing with electronic cigarettes, so you have people letting their guard down. Okay, this is a healthy alternative, the perception. Okay, well that kind of lessens the barriers or challenges to initiating that behavior. All of the flavors that are available in the different vape juices. We know that targets children, right? That's why tobacco companies are banned in the U.S. from having flavored tobacco products, right? Because you're marketing to an underage group, really, with those flavors. On the campus of FAU, right? We're a tobacco-free campus, but if you go and you look in the policy, vaping is also prohibited. And it has more to do with, it's hard to distinguish from a distance whether somebody's vaping or if they're smoking. So we just say, look, don't please smoke at all. And the other thing with the tobacco-free campus is that we have grade school age children on campus taking college courses. And just like public schools, grade schools are tobacco-free campuses, right? Because we have children on our campus, we kind of adopted that same philosophy when we enacted that policy. Okay, prevention of tobacco use. It's very similar to other prevention efforts. Okay, we kind of look through what are some things that you think these would be more effective than others. Okay, smoking cessation, helping people quit. So you have nicotine replacement therapy. So again, this is just a tool. These medical therapies are just a tool so that we can alleviate or ease with physiological withdrawal symptoms so that the person can focus on their cognitive behavioral therapy to change the behavior. Okay, social support. While the person is experiencing withdrawal symptoms, having a supportive social group, friends and family around you can go a long way in keeping you motivated. Relaxation training. Again, calming the physiological withdrawal symptoms. Problem-solving skills training. Again, if stress leads to smoking, like being able to resolve stress, by resolving the stressor, right? Here's where problem solving comes into play, or by coming up with different coping mechanisms. So there's a lot that goes into smoking cessation. Asking someone to quit, you just have to appreciate how big of a deal that is. even for people that don't smoke. And I ask each of you, think of a healthy behavior that you could improve in your own life, right? Whether it's eating healthy, working out more, getting more sleep, whatever it is. And the question now is, okay, well, if you're able to come up with, a healthy behavior that needs improvement, why haven't you made the improvements? Why haven't you made the change? It's because change is inherently difficult. And especially if with a behavior that has withdrawal symptoms, it's even going to be even more difficult to change that behavior. So, it's no surprise that there are many people out there that want to quit that just, they don't successfully do so. It's a difficult proposition. Okay, drug misuse. So the type of behavior has to be established. We change behaviors after we learn why people are engaging in behavior, right? So if you want someone to quit abusing drugs, using drugs, we have to understand, well, why are they using them in the first place? Then our countermeasure focuses on that exact reason why. Now, if we're talking about drug misuse, okay, misuse is a very powerful word in this case. So it's defined as using a drug for a purpose other than one prescribed by a licensed healthcare provider, or using amounts of the drug in a greater quantity than normally used. This is somewhere, they have a headache, that you look at the bottle, it says take two pills. Well, my headache's pretty strong, I'm going to take 4. If 2 is good, 4 must be better. So the intention isn't to use the drug recreationally. You're just, your intention is, look, I thought this is what you do when you want to maximize the effectiveness. In these cases, education can be very effective, saying, look, it doesn't work that way. You could actually be putting yourself in danger by increasing the dosage. Over the counter, they have a larger margin of error than with prescription drugs, but same point is, especially with prescription drugs, right? The physician is monitoring the dosage, right? In their professional opinion, this is what dose is going to be safe for you. Without the proper training, right, you may assume that, okay, well, if I double up or triple up the medication, I should, get a more profound effect, and it doesn't always work that way. So in that case, educating the person, saying, look, this could be dangerous. That may be all it takes to stop drug misuse. Now, drug abuse, that's a different intention. Okay, so abuse simply means that they are using the drug for a non-medical reason. And why are they doing that? Are they seeking the sensation of being high? Are they seeking the sensation of being kind of blunt their emotions so that you don't feel pain or depression or whatever? That's different than drug misuse. Misuse is just there's a misunderstanding and clarity and instructions. Drug abuse, well, that can be rooted in some deep psychological problems that are going to require more intensive view or more intensive approach to helping the person change that behavior. Okay, so most of these slides just go through in the book, make sure you're familiar with them. So just like alcohol use disorder, we have substance use disorder, we have 11 criteria. And, again, we're looking for the number of criteria that are present in the individual. Okay. So we go down here, same type of thing, mild, moderate, and severe based on 2 to 3, 4 to 5, or more than 6. Okay, commonly abused psychoactive drug. So stimulants, again, the person may feel like, hey, I need more energy to get this job done, right? So they take stimulants to provide that energy, depressants, psychotherapy. Again, whatever the effect the person is seeking, and they use the substance when they shouldn't, right? We're talking about abuse. opium, hallucinant. So again, each of these different classes of drug has its own unique effects. And if a person is chasing those effects, okay, we kind of know what type of substances they're most likely to abuse. Performance enhancing drugs, you know, allow them to perform at a higher level. Again, it's the thought process. If we're talking about anabolic steroids, you know, some of these hormones, you need a prescription to get them. If you don't have a prescription and you're in possession, you know, there's probably some illicit transaction occurred. Okay, prevention interventions for substance use, same type of deal, primary, secondary, tertiary. We're just giving some examples of, again, how to keep kids off of drugs or from even trying drugs. Secondary, how to get people to quit drug behavior before it becomes problematic. And then tertiary, prevention of relapse. Again, it's going to be more for long-term chronic users and their recovery. And then finally, we have some examples of public health interventions for drugs. So we have the FCU, across ages, so that's a school and community-based program, specifically for children, families and schools together, guiding good choices. So again, you can go into the book and get a little bit more detail about these. Okay, so that concludes the chapter lecture, and I'll see you on the next one. Okay, take care.